So how does that apply to pediatric dentistry? Do we use general anesthesia? The answer is definitely yes. It helps us provide a safe and comprehensive dental experience. There are some kids and some patients who have special needs who just cannot cope. And general anesthesia is a tool that we can use for that. So for patients with behavior, medical, or other problems, basically it lifts away all those cognitive, sensory, or basically bodily barriers that stop them from getting treatment done in the chair like others are able to. And deciding when to do GA for a kid is a big decision and can be hard. So we're going to look at a case of this kid. He's 6. He's got some holes in his teeth, Mom says. This is his first dental visit, so he's certainly later than he should be going to the dentist for the first time. No medical issues. And here's what he looks like. So he's got quite a bit going on, both in the anterior and in the posterior. You'd certainly be looking at some SSEs and some pulps. If I told you this kid was super well behaved, would you send him for general anesthesia? I need someone to pipe up. No, absolutely not, right? There's lots of kids, even 6-year-olds, even younger, who can handle this in the chair, who can handle the numbing. What if I told you we decided to try it in the chair and we started with the local and this kid was just like could not be consoled? He's crying, he's covering his mouth, he's kicking, he's fighting. Would you think about sedation at that point? Yeah, you're thinking about sedation at that point. And then you have to figure out what level of sedation is important to you. So I know in the last lecture, there's a slide about how many teeth. And that can be involved with this as well. So generally, we use GA for cases where there's a lot to do. Because your other ones only last so long, right? So your oral sedation isn't going to last a full hour for you to do 8 stainless steel crowns. It's just not going to happen. So sometimes general is for that. It also, those don't entirely put people to sleep. So if you need your kid who's super anxious, just like out, general anesthesia is going to be your option. So even though you've got a really severe case in terms of the caries, it doesn't always have to go to the operating room if the kid is able to handle it in another setting. I should have gone to this. Sorry, you guys got it though. I'm happy. Indications. This is really important. Some ideas of like sort of when you should be thinking about it. So the things we talked about, the physical, mental, or medical compromising conditions, a few of which we're going to talk about, that might make someone unable to do this awake. The local anesthesia is ineffective. They've got a really bad acute infection. There are kids who come into the hospital with these big raging infections, and you're not going to get that numb. And trying to get them open in order to get that numb is sometimes impossible. So that can be very useful. Then anatomic variations or allergy. The likelihood that your patient has a true local anesthetic allergy is incredibly low. If they tell you that, I would highly encourage getting allergy testing because it's not usually the case. But you don't always have to do local anesthetic if someone is under general anesthesia. So that can be a way to get around that. An extremely uncooperative, fearful, anxious, or physically resistant, uncommunicated child or adolescent. That's kind of our bread and butter of kids who end up in the OR. It's just kids who are too young, kind of below the age of cooperation. Extensive orofacial or dental trauma, you certainly see this. There are some kids who, even on a normal day, they would be able to cooperate and do it in the chair, and there's just too much has happened, and they're overwhelmed, and they end up going to the OR to have the trauma fixed. Protect the developing psyche or reduce medical risks. So there are some kids, we're going to get into this too, where other kinds of sedation, even though they don't have much to do, are not safe, or there's a highly, highly anxious patient and you don't want to kind of create an anxiety for them with the dentist. Immediate comprehensive needs or who otherwise would not receive care is important as well. Sometimes it's just an emergency and it has to go that way. There are, however, contraindications to the OR. Sometimes a kid is so sick that the risks of going to the OR are higher than what you'd actually benefit from receiving the treatment, so you have to think about that. Lab results that are excessively increased anesthesia risk. We'll talk about malignant hyperthermia. That's a lab result you certainly want to be aware of because certain types of sedation are contraindicated. Active systemic disease with elevated temperature, you don't want to be putting that out. A medical condition that's contraindicated to GA, so that is something like malignant hyperthermia. A healthy and cooperative patient, you don't really want to send to the OR. Someone with a respiratory infection, that just means their airway is really irritated, things like laryngospasms. And an Npo violation, something we talked about the other day too. So you really need to be on top of understanding when a kid can and cannot go if they've eaten or drank something. And we'll go over that as well. So pre-anesthesia considerations. So what do you need to think about before you're sedating that kid or even sending that kid for sedation? Medical consult. So you're responsible, and you don't want to be sending a kid where it's super high risk, because that would not feel good if someone has a complication. So there's more than this list that you might have to send that child to a specialist for. So endocrinology wise, type 1 or type 2 diabetic, we hesitate to sedate those in any place other than the hospital. And that's because you're responsible for maintaining their blood sugar at that point, which it's very difficult to do when you're also doing an oral sedation or an IV sedation. So oftentimes that's easier to do when they're under general anesthetic. Hyper and hypothyroidism can be very severe in kids depending on the level of severity of the disease, or parathyroidism. Kids who have seizures or other issues like cerebral palsy or spina bifida, you want to be talking to their specialist before you consider sedating these kids. Or kids who've had shunts for things like hydrocephaly. You want to make sure that everything's stable and that their specialist is telling you that it's okay. Well, sickle cell disease, other hemophilias or things like that, you need to find out, especially if you're doing extractions, if they need any pre-medication. The same thing with some heart defects. We've talked about when you have to give endocarditis prophylaxis. Those are all going to still be important with GA, and then also respiratory issues, so severe asthma, cystic fibrosis. We don't expect you to have like this list, but I really want you to, for real life, to be thinking, oh, okay, what do I need to talk to their doctors about? Because getting your medical consent is part of this. And then there are lots of implications with that too that you have to think about. So malignant hyperthermia, I've mentioned a few times. I'm not sure if you've heard of it. It's basically an inherited disorder that with certain anesthetics, especially things like Cebaflorin, which is what we use to get children asleep in the OR, can cause severe increases in their bodily temperature, which can lead to death. It's very significant. If it's not responded to quickly, the risk of death is incredibly high. So we make adjustments. If you know your kid has malignant hyperthermia, typically that's through family history. You want that kid to be the first case of the day because they flush the machine that delivers the medication, and they can give them medication that's safer for them. So you have to plan those type of pieces. We talked about the hematologic disorders. So do they need a pre-med? Do they need meds post-op? Do you need to take more local measures? Are you going to be suturing more often when you normally wouldn't? Kids who have things like Down syndrome, often you have to figure out what's going on with their neck. They can have some cervical spine issues between the atlas and axis, basically, that it's unstable and very, very easily, especially during an attempted intubation, you can paralyze that patient if things aren't all good. And then we talked about that prophylaxis as well. So all of those pieces need to be in your mind because this is a significant medical procedure that you're proposing for your patient. And then once you figure that out, you have to think, well, where am I sending them? Is this something that can be done in an outpatient ambulatory center? So, for example, at the new Main Street office where I am right now, we have a center lower where we're not doing GA at this point, but we are seeing different kinds of sedation. Whereas someone who is in stage 3 or 4, you're definitely going to want them to be in the hospital and potentially admitted for observation after the fact, which is normally not done for an outpatient surgery like dentistry. So pre-procedural preparation. This is a PEDS class. You have to think about a couple things. The OR, this is often the kid's first experience, this dental OR, and it can be really, really scary. And there's a couple things that can be done to try to help with the psychological issues here. A tour of the operating room is sometimes possible, not so much in adult hospitals, but for kids. We let the kids bring in their favorite toy with them just to help them feel comfortable. Pre-induction sedation, which we'll talk about. Sometimes they get a little medication before they hit the OR room just to keep them calm. Providing a non-threatening environment. That's something you guys can certainly take part in when you're talking to the kid before they get sedated. Keep them calm, keep them happy. And then you want to get their guardian back with them as soon as possible. That's for the kid and the parent. We were having issues with these videos, so I'm hoping they work, but please tell me if we don't, because we're going to talk about this, which is a child life specialist, which some of you may have heard of and some of you may not have.
A child life specialist works with patients and families in the hospital or another type of environment that helps decrease the stress and trauma of a hospitalization. So we give them a chance to manipulate medical equipment, try everything out. They can be the doctor, they take care of their stuffed animals, and sometimes us too. We prepare kids before surgeries, for procedures. We go into procedures, give emotional support. Translating the hospital into a language that kids can understand and feel comfortable with is a big deal. My favorite part about being a child life specialist is the relationships that you get to form with the kids and families. It's truly an honor to be able to work with these kiddos and these families on a regular basis.
All right, so hopefully you can hear that. If not, I'm sure it can be played back in your slides. So child life specialists, some people may or may not have heard of. We have them at Oshai. They are wonderful. I don't know if you've ever seen the little cars. They let the kids drive the little tiny cars to the ORs, which they love. They bring in these bubble towers that they can use. They help with the families and the siblings to make sure that everything's okay. We do use them with the dentistry stuff as well. But lots of kids who have severe medical issues are used to kind of working with child life specialists to make basically the whole environment a little more kid-friendly. Sort of a newer thing, but they're absolutely wonderful. Okay, hold on, this is not. Whoops, sorry, computer's being funny. So now you've gotten to the day of surgery. So you've gotten all your medical consults, everything's ready to go. You're showing up to the hospital, and says this kid, what do we need to know now? Number one, what we talked about before is their Npo status. So did they follow the rules that you said? We often tell them nothing from midnight the night before just to avoid any of these questions. But the real answer for how long is these things that you've seen before. So 2 hours for clear liquids. That includes things like a black coffee, pop, juice without pulp. Breast milk for little kids, little ones, is 4 hours. Infant formula, 6. Other non-human milks is also 6. A light meal, that's like a toast without butter, those kind of things. An iffy ground is 6 hours, and a heavy meal would be 8. To avoid any of that stuff, at least with UPD, we ask them to stop eating or drinking from midnight the night before the appointment, so that they're not taking guesses at what time. All right, hopefully this video also works. Okay, so we do a medical and a physical exam day of as well. So that child's physician needs to be consulted to complete a comprehensive medical and physical exam and any possible specialty visits as well that you've determined. That physical exam has to happen within 30 days of that appointment. So it needs to be close so that nothing is changing. And you need to review it before you hit the OR, okay? To make sure nothing has changed so much that you're now deciding that this is no longer safe. Consent is still very much important here. You should be talking about and kind of getting consent for the appointment beforehand, but you have to fill out a consent the day of. So talking about the benefits, the risks, the alternatives to GA have to be provided in a written form, and you have to document that you obtained that consent. You want to keep a copy of it. Typically written consent is required. Sorry. All right, pre-procedural sedation. So that's the kind of sedation that if you're getting it before you're hitting the OR. So the kids who are really, really nervous. So midazolam can be the answer for that. It can help smooth that induction of anesthesia, which can be a little traumatic sometimes. So typically between 0.5 and 0.75 milligrams per kilogram before the induction of GA. We're going to talk about what that looks like. That's not typical in our hospital. I know you've seen kids kind of coming in and they haven't been sedated at all. But especially for some people who are really aggravated, I've seen it a few times with kids with special needs. They might give them something beforehand just to make it a little less scary for them. Scrub protocol. So a dental procedure is considered clean rather than sterile. There's a lot of gross stuff happening in the mouth. It's not a sterile field by any means, but you should still be wearing sterile gloves. The gown is at the discretion of the dentist and sometimes the hospital itself. We always wear them. If you haven't been in the hospital, a helpful tip is that they don't have like small, medium, large gloves. They do it by numbered sizes. So if you want to look like you know what's going on, don't ask for small, medium, or large. But yeah, we still wash our hands beforehand just to keep everything clean, but you don't have to, this full procedure is not required. All right, monitoring equipment. This, on the other hand, incredibly important. There's a lot of monitors that get used. I know we talked about several of them with all of the other pieces. Obviously, with GA, the deepest level of sedation, you're going to use the most amount of monitors. Capnograph, pulse oximeter, going to monitor their temperature. Why would I monitor their temperature? What did I talk about before that I can pick up if all of a sudden their temperature is rising very quickly?
Malignant hyperthermia.
Correct. So the initial signals of malignant hyperthermia is a rapidly rising temperature. So sometimes, especially if patients may not know that they have this, and there are people who basically no one in their family's had any sedation, so this is the first time, and then that is an emergency. And a sphygmometer. Okay, so you can see them, they're putting the EKG leads onto the kid's chest, and then there's a little pulse ox sticker that goes onto their finger. A little easier than the clips that we have. Alright, hopefully this goes. Cebaflorin, so now we're talking about the actual induction, so the going to sleep bit. Hopefully this works. Okay, so Cebaflorin produces a rapid induction and the beginning of that general anesthesia. The odor is non-noxious, but honestly it smells like nail polish, so the kids don't love it. It's associated with less myocardial depression and less respiratory problems than other inhalation induction agents, so like isoflurane, for example. It's used for the maintenance of general anesthesia. So the Cevo is still used during the procedure. Typically, in ROR, they give them a lot of nitrous before the Cebaflorin, and that's because it just smells like not great. But they also do what you saw the the child life specialists do is they take clip chap to try to make it smell. Ooh. Ugh. Okay. So this is what it looks like. So often we try to get them to lay back for this. Sometimes they just won't have it. So you have to protect their head because they're going to be out and lean them back. We typically, for kids, don't establish IV access until this is over because they do not like IVs. But adults will very frequently come in with the IV already done. So IVs, in my opinion, were initially pretty scary to do, but they're actually not particularly difficult if you guys go into different specialties or do residencies. You might get to place them. So here's what it looks like on a kid. So just to talk over it a little bit, you want to come in a lot more shallow than I would initially thought, and you're looking for an initial flashback. So that flash of blood, red means you're in. You have to scoot a little bit forward after that because the needle is a little bit out past the cannula. You obviously need that cannula to be going into the vein. So once you see that flash, you move just like a millimeter or two forward, and then you slide that cannula off the needle. She's pulling back the needle. We never do that. Ours automatically retracts when you press the button for safety. That comes off and you connect your IV line. Takes a lot of practice, but eventually you get there. The intubation itself, for dental procedures, we typically use a nasotracheal intubation. It's preferred basically to have better access to the oral cavity because if you've got an oral intubation, there's definitely something in the way. It's not contraindicated, it's just a pain in the bum. So typically it's only used if it's like super minimal restorative needs, but even then we'd prefer nasal intubation. I can say, at least in my experience in the OR, which is still limited, I've only had an oral intubation once, and that's because of a trauma situation where the child had broken his nose and they didn't want to displace any nasal fracture, so we had to work around a tube, which was not very fun. For the nasal intubation itself, this one will not show you the red rubber, but typically in hospitals here they attach a red rubber non-latex round long string to it to try to help pull it through so nothing sharp and pointy from that endotracheal tube will cause bleeding in the nose. The issue with nasal intubation is it can cause more bleeding, and if you've got a patient with a really irritated airway, that might induce laryngospasm. So here we're using a glide scope to see the cords, which is where we want to be aiming, because if you go in the wrong hole, you're going to be in the esophagus. So see those little white two pieces? Those are the vocal cords, so not quite in the right spot yet. It's redirected. Almost. There you go. And then right through. You have to make sure you get that, especially if it's a cupped tube, which it was in that case, through the cords, because if you inflate that little piece in the vocal cords, you can damage them. Yep, and then the glide scope gets removed, everything gets attached. I think you guys will get to try that out on a dummy in your SIN lab sessions. So still in pre-procedural preparation, there's a lot going on. There's a lot of care taken to protect a kid's eyes. You don't want to be accidentally leaning on them. So this really cool contraption, ours is not as cool. It's like two pieces taped together. A shoulder roll is placed just to keep their neck in the right position. It also makes the dentistry a little easier. That endotracheal tube and the head are stabilized, so a lot of tape goes on in a very specific order in order to keep everything in place, because you certainly don't want that coming out. Radiographs in the operating room. We can do this. We do it sometimes if the kid is completely uncooperative before the OR. But you want to do this before you put the throat pack in, and that's because the throat pack has radiopaque threads in it. Now, why would a throat pack, these sponges, have radiopaque threads in it? Why would we design it that way?
So if you lose it, you can see if it's there.
Yeah. So if things get left or swallowed or go in the wrong place, they can x-ray the person or child and find them, which is not great, but it's certainly something you need to keep track of. So at least in RORs, you'll see them count out 10 at the end to make sure that we still have all of them. Your patient still needs to be wearing a lead apron for these x-rays, and so are the people in the room if they can't exit the room. Typically we prefer the digital x-rays, the lower radiation, but we can also use like I don't remember the word. Basically, they come in a little packet and you can self-developing, that's the word, the x-rays in the packet and take it out after. They're just not as good. So we're moving towards handheld digital x-rays, so the nomads, to try to reduce that radiation. We don't have them in ROR yet, although they're pushing for it. We actually do use those lovely self-developing ones. All right, the purpose of the throat pack. So the throat pack itself, you guys have seen go in. The nasal tube, endotracheal tube is in, and then we put that throat pack in the back. Why? To reduce number one, the escape of the anesthetic agents. You don't want to be breathing that in. First of all, not good for you. And second, you should probably be awake for the surgery that you're doing. It prevents material from entering the pharynx. So there's a lot of stuff going on when we're drilling at things, using water and all those pieces. You don't want that to get back. You want it to be tightly packed around the tube so that you've got a really good seal. The next one is a video of it being placed. Dr. Creighton has a very specific way that he likes to do it. You keep, I don't know if it's different if you're left-handed, hooked behind the tongue to try to pull it out of the way, and then pack it back and forth with your other hand. He does not like to see your left hand coming up if you're ever with him in the OR. Prior to the insertion, you saw him suction everything because you don't want to kind of push all that back. You're using a moist gauze, that throat pack, to put it back there. So why moist? Why would I wet it? Anybody?
So it doesn't stick.
That's part of it, but mostly so it doesn't catch on fire. So you can have sparks, and you've got oxygen, and then you've got something that can catch on fire. So they actually, before each surgery, to assess the fire risk of each procedure, because that is an issue. So you don't want that, because you can certainly have sparks with your hand pieces. You want to also indicate both orally and written that it's been placed. So when we place a throat pack, we say, okay, throat pack is in, to the room, we typically use a molt prop to open the child's mouth. They can't help you by opening their mouth at that point because they're under general anesthetic. You want to be very careful with the lips because they can't say, ouch, that's hurting. You could be pinching the lips with the mouth prop without even knowing, or the tongue. So local anesthesia can be used to minimize pain and bleeding after the fact. People say that it can minimize the use of opiates basically afterwards and decrease that sort of post-operative issues like nausea. There's a lot of different camps with this. I know some dentists do this and some of them don't. It's not going to help you during the procedure, but the argument is that afterwards the kid will be a little more comfortable. It also adds in the risk of the kid's numb now and biting their lip and all of those pieces too. So there's some trade-offs for that. I know with UPD we typically don't use local anesthetic. The treatment itself, we typically like a full coverage restoration on a primary tooth rather than something like a large amalgam on a posterior tooth, just because the kids going to the OR are considered high risk. If you have to go to the OR and get that much work done, you're probably a really high risk patient. And we want to make sure that they're not coming back to the OR. Unfortunately, we see a lot of frequent flyers, and you don't want that to be sedated again. It increases their risks. They're going back to the OR, an already inherently risky thing, when it all could have been done in one go. After the dental procedures, it's not uncommon to place like a topical fluoride or a varnish before the throat pack is removed, just to try to increase everything that you can. Now, I know I just said, okay, stainless steel crowns in kids, but you still think about what you're doing and what you're treatment planning. We don't typically put stainless steel crowns on anterior teeth. No parent is going to like you for that. And with special needs patients, sometimes we can use adult stainless steel crowns, but they're the ones that typically will get sort of a resin restoration, just because they're permanent teeth. So with permanent teeth, things are a little bit different. All right, the throat pack coming out. So a little suture is tied to the throat pack to easily remove it. So you'll see that. And you're going to see that the throat pack at the beginning is much more red than the throat pack at the end. And Dr. Creighton, who this video is of, is suctioning as he goes to make sure that nothing is kind of falling back into the throat. A throat pack that's red at the beginning and sort of more white to the end means that you've done a good throat pack, because nothing has sort of made it through all the way to the back. So we also announced the throat pack is coming out at the end, because you certainly do not want to be leaving that in the kid. All right, post-op orders. So if you're the attending on this case, you're gonna have to tell the nurses in the PACU what you want, or they very angry call you right afterwards. So there are certain protocols per hospital, so you have to consider that. So the PACU care for protocol of that particular hospital. You want that IV discontinued when released from the PACU. They can start clear liquids on the day of surgery. And then the if indicated list is if they need pain meds. It really depends on what you did. You took out a bunch of teeth, maybe. If you just did a couple crowns and a couple strip crowns, maybe not. Antibiotics if indicated. So not typical for us, especially if you've had an infection beforehand. Now you've removed the source, you may not need that antibiotic. They can typically be released the day of the surgery if all their criteria has been met. Now, this may not be the case if you've got a kid with a lot of medical problems that you want admitted. Sorry, this is my fault. Both of them say return appointment. It should say return appointment and basically your contact information if something goes wrong. I will get that fixed. What are the discharge criteria? Your heart function needs to be stable. That seems self-explanatory. The airway needs to be patent, uncompromised, and satisfactory. So they need to be breathing on their own well. Patient needs to be easily aroused with protective reflexes intact. So that coughing reflex, all of those kind of things to make sure that everything's safe. They're really drowsy afterwards. We have to be awake enough that we're comfortable sending them home. Their pain and bleeding need to be controlled. Ideally, that bleeding has been controlled before they've left the OR. We tend to put some sutures in kids if there's a lot of bleeding going on. The parent can sit with them, so the patient needs to sit by themselves and be able to move with minimal assistance. We showed you guys that last time on the other lecture. Being able to walk on their own is important. You have to have an adult available. Obviously, these kids are not taking their own sedated selves home. And no nausea or vomiting. So a side effect of some of these medications can be nausea. So you don't want to be sending a kid home who's like actively nauseous. Okay. Post-operative instructions. So those are the instructions before that you're giving to the PACU. This is what you're giving to the parent. So typically we give them written instructions as well, because you can tell them till the cows come home what you want them to do, and that doesn't always happen. So for diet and activity, you want them to be adequately hydrated. Clear liquids are ideal. Keep it soft the day of surgery. I usually recommend this regardless of what happens, even with crowns. That's a lot going on in your mouth. Just take it easy. But their diet is tolerated for the 24 hours post-op. And keep that activity limited. You want to be telling them no riding bikes, no running around. They're not going to school for the rest of the day. You just need to take it easy, day on the couch. Oral hygiene instructions is basically really easy. Just keep it gentle. You want to use either moistened gauze or towelettes, maybe for 1 or 2 days if they're really sensitive, and then regular flossing and brushing between that 1 to 4 days post-op, just depending on how invasive it was. Sorry.
Dr. Fraser?
Yeah.
Do you still want 2 adults with them, like one to hold the chin on the way home?
That's usually what we like, but with the hospital's regulations with COVID right now, they're only actually allowing 1 adult typically back with them. So that's tricky at the moment. Typically these guys are staying longer in their post-op than we are in like oral sedation. So while AAPD doesn't actually say, like, I can't tell you for sure, and we're not going to test you on this, basically saying, well, you have to have 2. We don't have to, it's just recommended. I would say 2 adults for this would also be recommended, just so someone can sit with the kid in the back. They're usually not having a great day after this at all. So, but I wouldn't worry about that too much. COVID has really messed a lot of that up. The pain management is the same sort of we talked about before. Tylenol or Motrin, how much to give for how long. If the kid's had a lot done, I